So now it's time to answer the questions, and the first question will go for Dr. Saleh. Dr. Saleh, what do you think about the reducing the isolation or quarantine period of medical staff to less than 14 days, sometimes even 1 week?
Thank you, Dr. Wael. Can you hear me?
Yes, we can hear you very well.
So,
It would be great if you can open your camera, please.
It's open.
Yeah. Okay.
Okay. So it all comes down to the detection of viable virus in respiratory specimen. So we don't depend on the PCR, the exit swab anymore, because we know that the PCR can remain positive for many weeks after the infection and does not equal a viable virus. For a person to be infective to other, he has to have a viable virus, which means that you can isolate a virus, that you can culture it. So studies in this regard show that patients who are asymptomatic or with mild symptoms, after, I don't recall exactly, but I think around 10 to 12 days, no one isolated a viable virus from a patient after the onset of symptoms. And that was the basics behind shifting from the test-based criteria to symptom-based criteria, where it says like 10 days after symptom starts, at least 24 hours. It used to be 72 hours, but now they reduced it to 24 hours fever-free without fever-reducing medication. However, those are with mild symptoms. Patients with moderate to severe disease, patients who are immunocompromised, they tend to shed the virus for a longer time, as I said in my lecture. So those patients, if you take it in general, about 95% of them, they will be free of viable virus by 15 days, and all of them should be free of virus by 20 days. So for patients with moderate to severe immunocompromised patient, the recommendation is 20 days after onset of symptom. So that's one side of the story in regard of quarantine the healthcare worker. The other side is what is the risk of this healthcare worker that he can impose on the patient or the people around him. For example, I guess you have to take more caution for example, ICU doctors, nurses, because they're dealing with a sick patient or immunocompromised patient. For another healthcare worker that works as an office with no encounter with sick patient, you might consider reducing the quarantine time. But below 10 days, I don't think that's wise, based on the available studies. Maybe in the future we have more idea or more data, and we will change our review. Thank you.
Thank you, Dr. Saleh. We have another question to Dr. Reem. Dr. Reem, we still see that the CT is more sensitive than chest X-ray in early stages. Why Fleischner Society did not recommend it even by low dose study?
They didn't recommend the screening program, but according to WHO recommendation, we can use CT imaging in general, chest X-ray and CT, depending on the clinical scenario. And I showed two cases, symptomatic and asymptomatic, with equivocal chest X-ray and equivocal PCR, that we did CT because of the presence of a ground glass opacity. It's not recommended as screening, but it's recommended when you need it for a diagnosis. Its low specificity and overlapped image of viral pneumonia with COVID-19 makes the screening program chaotic, and if you are screening 100 or 200 case, every single ground glass opacity you will mention as a COVID, and you will mix the cases if they are positive or negative, and by the end of the day, PCR is a must.
Thank you, Dr. Reem. We have a question also for Fawanea Hospital. I think Dr. Mariam can answer this question.
Yes.
Dr. Mariam, what was the percentage of the COVID confirmed patient who had CT, and what was the main indication for that? And another question also, did you use any scoring system for the severity of pneumonia in chest X-ray or CT chest?
Actually, for the first part of the question, no statistics had been established yet. But regarding the indication for CT, we're following the WHO recommendations as mentioned by Dr. Reem, yet a lot of conflict and discussion happened with the physicians as usual. And sometimes we end up by doing unnecessary CT, honestly. But the main thing that we follow is the WHO criteria. And also we do CT for non-COVID related conditions. We have a lot of quarantined areas, and from these areas we got cases for surgical management like pancreatic, for like appendicitis, cholecystitis, and do happen a lot. What the last question was?
Do you have any scoring system for severity of pneumonia in chest X-ray or CT chest?
Honestly, at the beginning, we did not follow such criteria, but recently, yes, we're starting by our senior radiologist to report such stratification and to see the severity of the pneumonia.
Thank you, Dr. Mariam. For the sake of time, I think we will not be able to take more questions. Dr. Mashal, please.
So I would like to, so again, as you said, Dr. Wael, we've been slightly passing the time. So we hope that you all enjoyed our first live webinar, and we'd like to thank all our respective speakers and our online guests. And thanks, of course, to our Head of Council, Dr. Nova Shimmeri, for her continuous support. Of course, that won't be our last webinar. We'll have a few more in the future. So please stay safe, put on your mask, and keep your social distance. And thank you very much, everybody. Thank you.